All right, so I want to start with a number. 20.
20 what?
20 markers on a lab panel. You know what your odds are of getting flagged as abnormal with at least one of them if you're perfectly healthy?
No clue. Tell me.
It's about 64%.
That's insane.
No, it's just math, right? Labs use a range that covers 95% of people. So 1 in 20 falls outside no matter what.
So that would mean the more you test, what happens?
Yeah, the more red flags you're guaranteed to get, whether or not anything's wrong.
That's the whole episode today, really. Consumer testing, 100 marker panels, optimal ranges that have nothing to do with your lab's reference range.
Why more information isn't always more insight.
And where it actually starts costing you money, time, peace of mind, maybe a procedure you didn't need.
I'm Ben Salento.
I'm Lee Mandel.
This is Vital Discourse. Let's get started.
Welcome to Vital Discourse. We're two physicians who take the health claims you're being sold and separate what the evidence actually proves from what the marketing invented. So you get a straight answer and a sharper question. The wellness industry sells certainty. We don't. Every week, Dr. Ben Salento and I sit down with the science, the medicine, and the policy that decide how long and how well you live. And we pressure test what gets claimed. I'm Dr. Lee Mandel, here with my partner in crime, Dr. Ben Salento. You can find us at vitaldiscourse.com.
So blood work used to be something a doctor ordered because they were looking for a specific answer, right? And today you can buy a panel with dozens or even hundreds of biomarkers, compare yourself against optimal ranges online, and repeat the whole thing every few months in the name of prevention. That's a little bit different now than it used to be.
Yeah, it sounds like it's empowering, and sometimes it is. But here's the problem, and we're going to unpack this. Every test creates the possibility of an abnormal result, and when you get an abnormal result, there's a question, right? Where did that come from? What does it mean? Is it temporary? Is it normal for that particular person? Did we find it only because we looked hard enough?
Yeah, we don't know about normative data here, right? So a lot of times it's in response to a question a patient's asking, hey, I have some symptoms, and then I want to come to my doctor and find out what those symptoms mean. Well, in the absence of that context, we don't really know what a lot of this data means. So we both see it in the office constantly. Patients arrive with a stack of self-ordered labs, a few values highlighted in red, and a shelf of supplements bought to chase those numbers. So today, when does blood work protect your health, and when does it turn a healthy person into an anxious patient? And I think it does all the time.
Yeah, and just to add on to that, what we're seeing now is companies like Quest or LabCorp that are advertising directly to the patient saying, hey, we have this blood test that can rule in or rule out this disorder that you may not have even thought of. And that's really scary because then, someone does the blood test and they don't necessarily in those cases actually need a doctor to order the blood test, right? Right. So let us say the disclaimer up front here because we do mean this. It's not an argument against preventive care in any way, shape, or form. What the argument is for testing that answers a question and against testing just because more data feels healthier. Okay, and that's really why we wanted to do this particular podcast.
You're going to start at the foundation, right? Before we talk about over-testing, Lee, what makes a blood test actually useful? Let's start there.
There are a few things. There's a defined question you're trying to answer. A patient in whom the condition is plausible. So not just doing the test for the sake of doing the test. So there needs to be acceptable accuracy within the test, an established way to interpret it, a meaningful next step if it's positive, and evidence that finding the thing earlier actually improves the outcome. And we're going to go over that because there's a Cochrane review that points to this. And you want to miss those, and you're not screening. You're just collecting numbers. If there's really nothing that you can pin that result to.
Yeah, and there are really three different jobs that a blood test is supposed to do, right? And so let's lay them out then.
So first is going to be diagnostic. Okay, so the test is ordered because someone, like you said before, someone has symptoms. They come with you with the symptoms, or they have a history that's pointing to something like a CBC or complete blood count that tests your hemoglobin or your hematocrit or your white blood cell count in someone with fatigue or suspected infection. Second is you're monitoring something. So, for example, someone that has diabetes, you're monitoring their hemoglobin A1C to see what their blood sugars have been over the last 3 months. And then last is going to be screening. So testing people that are without symptoms. So many of you have probably heard of the new blood test for colon cancer. That's a perfect example. And the evidence says that early detection beats the harms in a specifically defined group. And most of the trouble comes from treating a wellness panel as if it was screening when it's not actually earned that label.
Yeah, no, exactly. So give the clean example of real screening. What is real screening when you say that?
So let's go to the U.S. Preventive Services Task Force, which recommends screening adults 35 to 70 who carry overweight or obesity for prediabetes and diabetes. So notice in that there's a specific age band, a specific risk group, a specific condition, a specific action if positive. That's targeted screening. Okay, it's the opposite of ordering 100 markers on everyone and seeing what lights up.
And there's a place of evidence here that should stop people cold because it goes right at the annual let us check everything physical, right?
Yeah, and this is the one we should concentrate on. And I had spoken before about the Cochrane review. So the Cochrane review, basically what Cochrane does is they will look at the industry standards, the literature, and whatnot for specific item or specific medical issue, and we'll go through everything to determine what the medical industry is saying regarding that issue.
You and I know it because we used it all the time when we were in residency and studying. That was always the definitive thing, looking at the Cochrane.
Yeah, so the Cochrane review looked at general health, or general health checks, I should say, the broad testing of adults who feel fine. So 14 trials, roughly 180,000 people. That's a lot of people, okay?
Right.
I mean, realize there are millions of us, but it's not just 1,000 people, 180,000 people.
That's known as a very powerful study. It's highly powered, right? The more numbers that you have, the higher the number, the greater the power.
Right. So we always talk about in medicine what happens when n equals 1. So n is the number in your study. So
it's an anecdotal.
And you see that all the time,
sure.
Right? You see people, even we deal with this because we sit on panels at different meetings, and someone will come up and they'll say, "Yes, but I had a patient and blah blah blah." So, well, that's an n of 1. Right? You can't draw any conclusions off of one patient experience. It doesn't work that way, right? So the finding from the Cochrane review: general health checks did not reduce death or disease, not overall, not from heart disease, not from cancer. What they did do was increase the number of new diagnoses. More labels, no more lives saved, right? So we've got more diagnoses. What do we do with that?
Yeah, so that's the main line for this segment, right?
Right. A blood test is not preventative just because you drew it. It becomes preventative when the right test is used in the right person for a condition where finding the issue earlier actually changes what happens in the end.
Yeah, so basically what we're talking about, this is a classic example of extrapolating outside your data, right? That's the space shuttle problem. The O-rings, they had a certain amount of data, they extrapolated outside the data, the O-rings blew, and everybody died. So there's constant warnings in science.
I haven't heard about what actually happened with those O-rings. Explain that, because some people might not understand how to take what you just said and apply it to what we're talking about.
I think all of us remember, if you were around, we remember where we were when the space shuttle exploded. And the problem winds up being a classic cautionary tale in science, right? Because all of the launches, and again, I'm not a rocket scientist, but I can tell you that I delved into it because it was such an emotional thing. We were all sitting there. It was during the week. We were getting kind of used to these flights, and it was on in the background. I was in a place called The Cave, which was a traditional hangout at Trinity College, and we were in between classes, and suddenly the trajectory of that flame didn't look the same, and then we turned it up, and of course the tragedy unfolded. So things that happen, it was a launch that was done about 20 degrees colder than any of the launches, and I forget the exact temperature. I think it was around 30 degrees or 29 degrees. Most of them had been at 50 degrees Fahrenheit. And so because in this window of normative data that they were looking at from about 45 degrees to 90 degrees, there were never any problems with the O-rings. The NASA had extrapolated and said, well, temperature has no bearing on O-rings, but they were 20 degrees colder. So they extrapolated outside of their data. They had tons of data in the normal temperature range and erroneously concluded temperature had no bearing.
And I presume that those O-rings were made of some type of rubber material?
Yeah, I don't know the exact material. I don't want to extrapolate outside my data, but I can tell you that when you do that, I remember it sort of really being a profound look at what happens when you start making assumptions outside of where your data is. So if you have data based on people coming in, perfect example for me, a personal example, my stepfather, he had heard about these whole body CT scans and whole body MRIs, and a friend of his had one done. And this guy came in and he was like, Howard, you got to get yourself a whole body CT scan. I found a cancer in me. So he set about, well, I'm going to get a whole body CT scan. I warned him against doing that because, again, you don't really know what to make of certain things when there's no basis in a symptom. And so he went and got it, and he found a little tiny spot on his lung, and the doctor told him, let's just watch it. Well, he didn't want to do that. So he said, well, I was coughing up blood because he read it online. Well, now that's totally different. Someone who's coughing up blood and a doctor hears that takes you into a completely different realm. Well, it wasn't true. And so he wound up getting a wedge taken out of his lung. It turned out to be a small granuloma, a nothing. And during the procedure, though, he had a complication. So now, again, this is extrapolating outside your data. There was no basis in reality for his symptom, and so it took him down the wrong path, and he had a complication during the procedure. So, we see this kind of stuff all the time, and it can actually do harm. So you have to be careful, right?
And it brings a question. We promise on this podcast to give you better questions. And it brings a question that should always be asked to your physician in this type of situation. And that is, if I do nothing and we watch it and it ends up being something, have we lost any ground?
Did we lose time?
Right. If you look at the data, if it is now we're dealing with a nodule that's 1 millimeter in size and it grows to 2 millimeters in size, and then we biopsy it or take it out. What is the natural history of that disease process if, for example, it's a cancer? Is there an increased risk now that we'll have distant metastasis? Is there a decreased chance that we'll be alive 5 years from now or 10 years from now? What's the disease-free survival if it's a 2 millimeter tumor as opposed to a 1 millimeter tumor? And that really should guide these types of things, because if the answer is there's absolutely no difference between a 1 millimeter and a 2 millimeter when we look back at all of the normative data that we have, then why go ahead with a wedge resection?
Right.
Makes no sense.
But we all have it. We all do. We don't really do that, do we? We always look at the outcome and then try to blame something if it's bad. So we look to whatever we did. Was there a delay? Did I get in on a Monday instead of a Friday? Right? I mean, we all if the outcome's great, we don't ask the question. If the outcome's bad, we try to look for something in the process and blame it. I mean,
Exactly.
I think that's just human nature. So there's a paradox here that trips everyone up. A perfectly healthy person orders a big panel. It comes back with 3 values, just say, in red. How'd that happen?
Well, it's built into the math. Once you see it, you can't unsee it, and that's really the problem here, right? That's when patients start freaking out. A laboratory reference range is usually defined to capture the middle, kind of 95% of a healthy reference population, and what that means is, by definition, about 5% of perfectly healthy people fall outside the range on any single marker. The red flag doesn't mean disease was found. It means the value sits outside that lab's chosen interval.
Correct. And so this is the same sort of thing that we see all the time. These ranges change sometimes, and for reasons that are not disease-driven. A perfect example is, in America, normative ranges for blood pressure used to be about 160/80. Around just after World War II, and they changed that arbitrarily to 120/80 for reasons that had nothing to do with disease. So we also have to kind of look at the culture of it and how things are changing over time. You're going to have people that fall outside that bell curve, right?
Yeah, and the thing is, what people also don't realize is when these tests are taken is important. It matters, right? So if you, for example, take a triglyceride test to see how much triglycerides are in your bloodstream, and you have a meal the night before that is heavy in triglycerides, your level is going to be elevated, and it's going to be flagged.
Right.
And that doesn't necessarily mean that anything is wrong.
Right.
And the 160/80, well, when was that blood pressure taken? Was that blood pressure taken under a high stress condition or those types of things? It's normal for the upper number, the systolic blood pressure, to be elevated under those types of conditions.
Historically, some of the pharmaceutical companies pressured the FDA to make the change because not enough people were supporting the blood pressure meds, and so it was actually. And this is well documented. This is not like a conjecture or anything or a conspiracy theory. They actually pressured them to kind of make the change because they wanted to support the industry and have more people on blood pressure meds.
Yeah. And when you're dealing with these abnormal tests, it really gets compounded. So if we do the math, if one marker has a 5% chance of being flagged in a healthy person, then across 20 independent markers, the odds that at least one flags is going to be about 64%. That's a high percentage chance that you're going to have a flagged outcome on a blood test. Across 30, about 79%. Now, I'll be honest that those numbers are just an illustration because lab values are correlated, not perfectly independent. But the principle is still the same. Order enough tests on a healthy person and an abnormal result becomes not just a possibility, but it's likely that you're going to see it.
Yeah, so it's important that we understand here, especially when it's done out of the blue without any link towards a symptom. Abnormal is not the same word as disease, right?
Not even remotely. A value lands outside the range because of, like I was just saying, time of day, hydration, harder work the day before, where you are in your menstrual cycle, a supplement, whether or not you fasted, a cold coming on, or just normal biological, what we call biological wobble. Right? So outside the range is a prompt to think about what's going on, but it's not in and of itself any type of diagnosis.
And this is where working with the doctor is super important, right? So there's a distinction between that people always conflate the reference range versus the treatment threshold, right? So just because there's a red line there doesn't mean you're suddenly looking for a treatment. There doesn't mean that there's a disease. It just means that there's something that should be discussed and talked about.
Ben, go over how these ranges are actually created.
So basically, this is a statistical thing. Anything that you're looking at You're going to take at least 120 people or so to make sure that there's enough power, and you're going to look at all of their values, and you're going to make sure that these people are as healthy as possible. So there's some error built into this in general, but then you're going to take that middle 95%. And you're going to shave off the two tails, 2.5% on the low side and 2.5% on the high side. And you're going to basically get this bell-shaped curve. And then you're going to analyze that curve statistically, the way you would with anything. Right, so that's where you get your variation, statistical probability variation. You're going to get your median and your mean, and then you're going to shave around the sides of it to come up with a system of understanding what is in fact normal. So it's got a lot of wiggle room, even statistically from the way that you develop it. Everything in biology, therefore, is sort of seen as a bell curve. It's not binomial. It's not all or nothing, but there's a range, and that range is determined based on outcomes, right?
Yeah, and that's where the 5% comes in, the 2.5% on either side that are quote unquote normal. That 2.5% is shaved off to create the range within the bell curve, but those are otherwise normal individuals from a medical issue standpoint, but with a quote unquote abnormal blood test.
Yeah.
And so the reference range just describes where most people's values sit. The treatment threshold asks a totally different question. Whether or not we treat. At what value does the evidence show that intervening actually improves your outcome? And that's not necessarily the same number. And I'll explain that in this way. So if we have someone, for example, that when they were younger had a testosterone level that was at the high end of normal, okay? So say at your particular lab, testosterone levels go up to 900. Okay, so say you were 850, and now you're 45, 55 years old, and you're now down at 250. Well, 250 might still be in the range, but you might feel like garbage.
Yeah.
So even within those ranges, just because you're within the range doesn't necessarily mean that there's not something going on with that blood test or with that issue that's causing you symptoms.
Yeah, we see that a lot with thyroid too, right? A lot of people coming in having symptoms of low thyroid, but you look at it and it's inside the normal range, but it's really low. It's right at the borderline. So, you have to try and treat that patient based on what they're telling you also. You didn't know them before. You don't know where they were at before. They might have been sitting very high, and now they're low normal, but for them, it's decidedly abnormal based on their history and their symptoms.
And the thing is that not everyone with a blood test at that specific number is necessarily going to have symptoms from it. Sometimes the difference is that it changed over time within the range.
Imagine that the doctor's important. Talking to your doctor and getting a history is important. What a concept.
And therein lies the problem, because what people see is on social media, you're getting inundated with, if this happens, it's bad. If you have this number, it's bad. It needs to be fixed. And that's not necessarily the case.
I'm finding that people are putting more faith in influencers than their physician quite often. I don't know if you're finding that also, but
yeah, we call it Dr. Google.
Yeah.
Right? Patients come in, well, I read on Google that blah, blah, blah. And now I read on ChatGPT, or I read on Claude.
Right.
So big panels don't just discover more diseases. They discover more harmless variation. And they package the two to look identical.
Yeah, that's true. So the obvious pushback is, fine, just test everything and ignore whatever turns out not to matter. Why not? Why don't you do that?
Because, look at it. You can't unsee an abnormal result. Okay. And your doctor can't either. So
Now you got to deal with it. Yeah.
right, for two different reasons. Number one, obviously you don't want to miss anything, and because you care about your patient. But the other, and quite frankly, is medical legal. If there's an abnormality, we're required to look into that.
Yep.
Okay. Once it's on the chart, it tends to set something in motion.
Yep.
Repeating labs, a referral to another physician, some imaging, sometimes a biopsy, like you said, a procedure where part of a lung is taken out.
Well, how often have you seen this, Lee, where hey, a young female patient has globus sensation, they go to their doctor, and they get an ultrasound because of it. So, of course, they find a small little nodule in one of the lobes of their thyroid, and it's probably innocuous, probably means nothing, but now you're dealing with a thyroid problem. And that's you're going to be getting a biopsy. You're going to be following that over time. It probably meant nothing. It was certainly not related to your globus, but now you're dealing with that, right? You see that a lot.
And think of the anxiety that it provokes.
Oh, yeah. Which was probably causing the globus sensation, the lump in your throat to begin with.
Right, exactly. But the self-monitoring and this monitoring can go on forever. You're to your point, you have a small thyroid nodule. When we see a thyroid nodule that's less than 1 millimeter in size, you watch it. It's usually not a big deal. Plenty of people have thyroid nodules, but to a patient that's following that doesn't know any better, that's a huge deal. And there's a name for this, jumping from we have a lab, and then we have a referral, and then we have a diagnostic study, and then we have a biopsy. It's called a cascade of care.
The cascade. Yep. And this is measured. This isn't hypothetical. This is real.
Yeah, it is measured. In a 2019 national survey of U.S. internists that was published in JAMA, the Journal of the American Medical Association, of the physicians who responded, 99% said they experienced one of these cascades after an incidental finding. This isn't a fluke, okay? It's essentially universal. We all see it. About 1 in 5 reported fielding patient calls about cascade-related findings every single week. And more than half said that these cascades had caused their patients real harm, psychological harm, physical harm, or even financial harm.
Yeah. So let's say the harm plainly, right? Because cascade sounds like a nice, happy, soft word.
Right. So the harm is you start out with a healthy person. The person gets a scan they don't need from a lab they didn't need that finds a spot that was never going to hurt them, which leads to a biopsy that carries its own risk and months of fear. The first blood draw felt free. Everything downstream wasn't.
Right. And so that's just going back to my stepdad, Howard. He wound up having a heart attack, perioperative heart attack, around his wedge resection. So his cascade had a real consequence. And he's passed away now from other things. But it was a 2.5-year odyssey that we went through simply because he went and got a CT scan and then fibbed to his doctor. So these things can really have a harsh outcome. Right.
So it's the down the line harm.
Yep.
Right. It's not the harm. The needle, the blood draw doesn't cause any harm. It's what happens after that's the harm. And from a legal perspective, right? We talk about in law the chain of liability. Okay, and where the chain of liability starts and where the chains of liability can be broken or not broken, but there is really no. Currently, in the way we look at these things, there's no liability from the perspective of the person that recommended having that blood test on social media, or Quest.
Yep.
Right? There's no liability there. They've set this into motion, but the liability doesn't come from them.
Yeah.
It comes down the line from the practitioner who was forced to act on this abnormality.
Right. Now, once it's there, you have to sort of do something about it medical legally, right? But let's be constructive, though. So somebody wants to be proactive. How should they approach blood work then?
So start with the individual. Start with a person, not a panel. You have to take these things into account. Their age, their symptoms, their family history, the medications they're taking, whether or not they're pregnant, whether they've been exposed to specific things, whether or not there are existing conditions, whether there are actual risk factors. The test should be chosen to fit the picture of the patient. It shouldn't be pulled off of a menu of 100 markers that just happen to be there.
Yeah, so give people the questions to ask before any test gets ordered. Then I think that might help people that are watching.
Yeah, so there are around 7 of them. What condition are we actually looking for? How likely is it in this specific person that this condition will occur? Is the test accurate in this setting? So I'll give an example of that. We have now blood tests that are coming out for Alzheimer's, or at least being billed as tests for Alzheimer's. And they don't necessarily test the amyloid level, but they test a marker of the amyloid level. What is the accuracy of these tests in determining whether or not someone's going to develop Alzheimer's? The answer is, in many cases, we don't even know. And people are being given these tests. It's being marketed by these blood testing companies. And we don't even know the accuracy of the test at this point. Okay? We need to know, what are we going to do if it's high? What are we going to do if the test is low? What are we going to do if the test is borderline? Would it be smarter to repeat it later than to act on it now? Has screening for this type of test been shown to improve outcomes? And the question that people seem to never ask, could this test, actually the result of this test, create a label without creating any benefit?
You hit on something really important there, Lee, and that's the false positive paradox, right? So when something is very common in society, right, like high blood pressure, something that's very common, doing a random test on it is actually very beneficial. But when a disease process is rare, quite often the positive is a false positive, and it's a statistical anomaly. It just happens. So when you're looking for rare things, quite often you'll find them and they mean nothing. So again, you without any symptoms, you have to be very careful just randomly getting tests.
And here's where that comes into play. So I'm sure you, as well as I can tell you from my specific experience, when you order labs that are designed to test, for example, for autoimmune diseases, one of the markers is an ANA, anti-nuclear antibody test. False positive ANAs we see all the time. I mean, all the time. Now what happens? You have a positive ANA. What does that mean? That means you theoretically have an autoimmune disorder. Well, what does an insurance company do with that information? Right? What is the insurance company that is underwriting your death benefits going to say about it? Right? So you have to think about this. This information is becoming more and more, our information is becoming more and more ubiquitous. The idea, and I think this started with the more current law, HIPAA and whatnot, the Affordable Care Act, is that our information, our medical information, is supposed to be becoming more globally able to be obtained by insurance companies.
Yeah.
Okay? We think that HIPAA is protecting us, that it's protecting our private health information to an extent, but also built within that system is the potential ability for insurers to get their hands on this information.
Yeah.
And when they get their hands on this information, it's going to go into the underwriting.
That's true. And I think that's, I don't think that was the intended idea. I think it's an unintended consequence of HIPAA. HIPAA was designed to stop docs from talking about you in the elevator so that people could overhear. And that's the situation that's always given in those self-paced texts. But in reality, it was designed to protect you from things like that. Turns out it's actually exposing you to it. I don't think they intended that when they wrote the law.
No.
So there's a principle underneath all of that, right? The one from Bayes. I mean, and that's what I was addressing before, right? The pretest probability.
Exactly. So the same result means completely different things depending on how likely the disease was before you drew the blood.
Right.
A mildly abnormal value in someone with no symptoms and no risk factors is usually just noise. That exact value in someone with symptoms and family history is actually a signal The number on the page doesn't carry its own meaning. It's the context in which that blood test occurs.
Right. So the main line then?
So, good preventative medicine is not measured by how many biomarkers you collect. It's measured by whether the testing leads to a better decision.
So it's time for our vital message of the day then, where we take the myths going around and give you what the evidence actually says. So, Lee, blood work has generated a lot of them, right?
Yeah, myth number 1, a comprehensive annual panel catches every disease early.
And reality, many serious diseases have no useful general blood screen at all. A routine panel does not rule out most cancers. There are some exceptions, obviously. Neurological disease or autoimmune disease as well. And remember, the Cochrane finding, broad health checks increase diagnoses without reducing death or disease. It's not helping you. Better framing is blood work screens for selected conditions. It's not a full body guarantee. It shouldn't be used as one.
Exactly. And to that point, I have patients that come in almost on a routine basis. And when there's a finding where I say, well, this could be a cancer, many times I'll get back, well, but all my annual blood tests have been normal. Wouldn't they have caught it?
No.
Right? No.
Unfortunately. I mean, there are some blood tests that are coming out that can suggest cancer, most notably colon cancer. But that's rare. I mean, that's the exception. There are more coming out, but right now, regular blood tests don't tell you much about cancer.
Vitamin D should be checked routinely in every healthy adult. This one is actual evidence behind the skepticism.
Yeah, I mean, the U.S. Preventive Services Task Force concluded the evidence is insufficient to know whether screening asymptomatic adults for vitamin D deficiency produces a net benefit. That's another example of this. Their review found no demonstrated benefit from treating screen-detected low levels for mortality, fracture falls, depression, diabetes, heart disease, cancer.
Yeah, and here's where we really have to be very careful, because skepticism does cut both ways. Insufficient evidence does not mean proven useless. It means we do not have the proof either way. So we don't know if it's positive, we don't know if it's negative. So vitamin D testing absolutely has a place in people with bone disease, malabsorption, certain medications, and of course, patients that have real symptoms. The point is context, not reflex. It should not be auto-added to every wellness panel.
Well, here's the thing, though. Another thing. So very few vitamin D supplements work. There's really nothing better than sunlight. I mean, sunlight, there's a huge push on, especially with the large tests, large studies that are coming out showing that sunscreen actually is a higher cause of cancer than sun exposure itself. That's sort of muddying the waters. But there's a whole light therapy. Dr. Jack Cruz talking about light therapy and how exposing yourself to sunlight is good for you in general. A lot of it's done through the massive increase in appropriate vitamin D in people that get regular sun. And so the vitamin D, I think we're going to come back to this, and I bet we're even going to do like a full episode on it, because none of these supplements really get your vitamin D up. So you'll be chasing that number, going through a million different lipospherics and pills and whatnot, and really just getting an appropriate amount of sunlight can fix it almost instantaneously. And I've seen that in myself, because I have a wellness center, and so I do panels quite a bit. So this kind of hits close to home for me.
And for people that you do recommend vitamin D, do you also recommend K2?
Absolutely, yeah. I mean, we should probably focus in on certain supplements and do a whole series on it, because there's such a massive expansion in the business of supplements, and there is a difference between good supplements and bad supplements, and we should really sort of go through those. Vitamin D falls squarely in that realm. Everyone's chasing it. Everyone has a fix for it, and very few of them really move your numbers.
everyone should get regular thyroid panels, even without symptoms.
Wow. So I'm not a big fan of that. This is the same posture for me. Again, the task force found insufficient evidence that screening asymptomatic, non-pregnant adults for thyroid dysfunction improves outcomes. And treatment of screen-detected thyroid abnormalities has never been shown to meaningful improvement in quality of life, weight, blood pressure, lipids, cognition in trials that we have. And the same caveat holds, right? So with symptoms, pregnancy, or risk factors, thyroid testing is genuinely valuable, okay? So that's for sure. Universal screening of people with no reason to suspect it that part is not supported. So we're not trying to say don't screen for thyroid problems, but you do it judiciously when there's a reason to screen, not just out of the blue.
And thyroid's really a tough one because there are a lot of components to thyroid testing.
Yes.
So if you're just doing a TSH, a thyroid stimulating hormone test, and that's it, and it's on the high side or on the low side, what does that mean? Well, it means absolutely nothing without knowing what the free and total T3 is and the free and total T4 is, and it's just so far beyond the just actual screen for the TSH.
Right.
If a test is available directly to consumers, it must be clinically useful.
Well, reality, remember, this is marketing. It's a business. Availability is not evidence. A lab can measure something perfectly well without any proof that testing healthy people for it improves anything, right? So the FDA itself cautions that direct-to-consumer results may need clinical interpretation and confirmation. Again, work with the doc. And the result does not by itself tell you whether you will develop a condition. So being able to measure a biomarker is not the same as knowing what to do with it. And that's the key point here. And that's the reason that docs are around and can help you with this.
Yeah, and I'll go back to my example of the amyloid test.
Yeah.
When you get that, there are a couple out there right now, but I think the one, if I'm not mistaken, that's provided by Quest. Basically, what it tells you is low likelihood, medium likelihood, higher likelihood that you will eventually develop dementia. What do you do with that?
Yeah.
I mean, seriously, what do you do with that? So the last one, if all my blood tests are normal, I know I'm healthy.
So reality, normal blood work does not rule out every disease or explain every symptom. And it does not replace the physical exam, appropriate screening, blood pressure, sleep, mental health, or how you actually function. Blood tests are one part of a health assessment, not a certificate of health.
The goal is better health. So that's what we're here for, not a better dashboard. Those are not the same thing. And chasing the second one can cost you the first.
Okay, so let us talk about the human cost, because there's a line where proactive testing quietly becomes compulsive reassurance-seeking, right? How do you know you've crossed that line, Lee?
Well, let's be honest with ourselves. You repeat normal panels with no new reason, okay? You order more tests after every borderline value. You're constantly comparing yourself to online optimal ranges. You're swapping supplements based on tiny fluctuations in your blood testing. You feel like you can't trust your own body without a recent number. You bounce between clinicians until someone finally agrees to treat a borderline value. And the reassurance from a normal result lasts about a day before the worry comes back that your next blood test is going to be abnormal.
Yeah. And what we want to be careful here, because this is not, it is all in your head, right?
Yeah, and this matters. The symptoms can be completely real. The point is really narrower. The testing process itself may have stopped reducing uncertainty and started manufacturing it. When the tool meant to calm you is the thing that's actually generating the anxiety and the fear, the tool's the problem, not you.
The tool's become the problem. You're the tool.
Yeah, you're a tool.
Don't be a tool. So what's the main line? Don't be a tool?
Yeah, well, the testing's supposed to answer questions, but the problem is that every answer spawns 5 new fears and more questions, and the strategy needs to change, not escalate.
Yeah, so that's the necessary counterweight, right? Because we're not telling anyone to ignore their labs. What actually makes a result worth acting on is something that needs to be asked. So what actually makes a result worth acting on then, Lee?
Well, it's more than one thing. So it's not any one thing alone. How far outside the range is the blood test? Is it new, or it's been persistent across blood draws with no change in symptoms or anything like that? Where there are several related markers that are telling the same story. So we spoke about the positive ANA. A mildly positive ANA by itself means absolutely nothing. But if you have, say, a moderate positive ANA and a positive ANCA and a positive rheumatoid factor, now we're talking about some type of significant autoimmune disorder. Are there real symptoms attached? Is something ordinary, fasting, a workout, a medication, dehydration, illness could explain it. Whether it should be repeated before anyone intervenes, and whether there's an actual validated treatment threshold, not just a population range.
And you weigh that against the cost of waiting, right?
Yeah, exactly. And that's what we were saying before. The question that you need to ask is, if I do nothing and something does come of this, have I lost any ground? Right? And that's the real question that you need to ask your physician. Some values need action right now. We know that. A genuinely dangerous result gets addressed promptly. Full stop. There's no question about it. The argument against over-testing is not an argument for ignoring a result that matters. It's an argument for interpreting instead of reacting. The right response to an abnormal value is neither panic nor dismissal. It's interpretation.
And that's the doc. Coming back to the doc.
If this gave you a better question than the one you walked in with, that's what the whole point is. That's what we're here for. Do 3 things. Tune in, because we do this every week. Subscribe, so you never have to come looking for us. And send this to one person, a friend, a colleague, who would be sharper for having heard it. That last one really matters for us. We don't run ads. We don't chase clicks. This show grows one referral at a time from people who trust the person who sent it. That's you.
So here's the bottom line. Blood tests are among the most useful tools in medicine, right? They diagnose, they guide treatment, they reveal risk. But a test does not become more valuable because it's available. And your health does not get more precise just because a dashboard has more numbers on it.
Yeah, the goal is not to test the most. It's to ask the right questions, order the tests that can answer those questions, understand what the results can and can't tell you. Sometimes being proactive does mean getting tested. Sometimes it means resisting the urge to turn every normal fluctuation into its own medical problem. For Vital Discourse, I'm Dr. Lee Mandel.
And I'm Dr. Ben Salento. Find everything at vitaldiscourse.com. We'll see you next time.